Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia. I welcome you to our ongoing webinar series that accompanies the Innovations in Hepatitis Elimination series in the AASLD Journal of Clinical Liver Disease, where we talk about a publication in that series. And today we're going to be reviewing the results of a survey where we ask clinicians to on their care delivery of hepatitis prevention, testing, and treatment services. And I'm very excited about having the lead author of that survey, Jessica Laury, and four of my colleagues who responded to the survey and who will be giving you a sense on a personal level about how that COVID-19 response impacted their work. And I think as a start, we'll just go around, have everybody say hello that's on our panel today, and then I'll turn it over to Jessica. And I'll start with Jessica and then Bernadette, and go around the circle here. Jessica.
Perfect. So my name is Jessica Laury. I am a second-year epidemiology student at the Rollins School of Public Health at Emory, which is based in Atlanta. My focus is infectious disease, and I currently work as an intern at the Coalition, doing kind of some data analysis projects, and that's what led me to work on this paper.
Great. Bernadette.
Perfect. My name is Bernadette. I'm a nurse with the Toronto Community Hepatitis C program. So it's a community-based Hep C program out of a community health center in Toronto, Canada. So I work with a fairly robust harm reduction program within priority populations that have been identified by the provincial government, which include Indigenous folks, people who inject drugs, and people experiencing homelessness.
Thank you. Dr. Singh? Dr. Singh?
Hi, everyone. My name is Ashina Singh. I'm one of the gastroenterologists and transplant hepatologists here at Henry Ford. We're based in Detroit. So we have a pretty large catchment area. For those who don't know, Michigan has very remote rural areas, and we are obviously based in a very urban, underserved setting. But we take kind of, because of the scarcity of hepatology in this state, we do serve all those areas. So thank you for having me today.
Thank you for joining. Dr. Spearman.
Hi, I'm Wendy Spearman. I run the liver clinic at Kruger Hospital. This is a national and provincial referral center for patients with chronic liver disease, particularly viral hepatitis. And our predominant problem here is hepatitis B, with an increasing hepatitis C in our injecting drug user population.
Thank you. Also, Wendy also runs a ECHO network for Africa that provides a means of clinical training for physicians and other clinicians caring for people with hepatitis. And so it'll be interesting to hear if she's learned from other experiences through that network as we have our conversation later on. Dr. Marinho.
Hello, I'm Rui Marinho. I'm from Lisbon, Portugal. I'm a gastroenterologist and hepatologist, head of the Department of Gastroenterology and Hepatology Hospital Santa Maria, which is the biggest one in Portugal. I'm also president of the Portuguese Society of Gastroenterology, and in my department we have a multidisciplinary team called C-Free team, going outside the hospital, the homeless, harm reduction risks, to go to prisons, mental diseases, so for the last 2 years. Great,
excellent, thank you. Huey. Jessica, why don't we get started? Give us a brief overview of the results from our global survey, and then we will proceed with our conversation. Thank you.
All right. Everybody see this okay?
Yes.
Perfect. Excellent. So before I hand you over to our wonderful panelists, I wanted to take this opportunity to just run through some of our findings from the survey. So our survey was available in English, French, and Spanish, and was disseminated by some of our coalition partners for completion between the months of August and December of 2020, with the bulk of our responses coming in October. Ultimately, we had 103 participants from 44 countries, the majority of whom were working in clinics as program managers, MDs, or nurses, The bulk of our responses come from the African, European, and American region, with fewer responses coming from the smaller Southeast Asian, Western Pacific, and Eastern Mediterranean WHO regions. For many of our questions, just as some background, we asked participants to reflect on clinic operations during the month of highest COVID impact, so the worst month related to COVID for them, compared to a typical pre-COVID month, and then again asked them to reflect on the current month or the month that they completed the survey using a typical pre-COVID month again as baseline. For most of our participants, the month of highest COVID impact was March or April, and most surveys were completed, so that month of survey completion was September or October. One of the focal points for our survey was change in clinic-based care as a result of COVID. So we asked our respondents to report how their clinic volumes had changed during the highest impact month. As is to be expected, almost all of our respondents reported decreases in patient volumes, with 21% reporting greater than 50% of their HPV treatment being deferred or delayed, and 39% reporting that more than 50% of their patient volumes had dropped for hepatitis C treatment. So we did see slightly more dramatic results related to hepatitis C. In addition to quantifying decreases in care, we were interested in what challenges were preventing clinics from returning to pre-COVID normal levels. 55 of our respondents were able to provide some details on what they perceived to be the biggest obstacles preventing them from returning to pre-COVID patient volumes. Universally, we see here that patient anxiety and fear are the biggest hindrance, but when we stratified based on WHO region, we did see some interesting regional differences. For example, loss of space was the next most reported challenge in European countries. Similarly, American countries reported limited space and challenges with limited staff as kind of the biggest hindrances for them. African respondents reported slightly different challenges that really focused on public transportation and inadequate PPE supplies, preventing them from returning to normal levels. In addition to reporting challenges, we wanted to ask participants to report on insights on how they were adapting to meet patient needs despite the pandemic. Many facilities implemented new infection control measures, changed clinical care strategies, and employed communication techniques to connect with their patients. Clinic staff wearing masks was overwhelmingly the most implemented infection control measure, with nearly 90% of our respondents using this tool. Patient masks, screening patients for COVID symptoms before they came to the clinic, and implementing new and rigorous cleaning measures were also reported by more than half of our respondents. Facilities also minimized their risk by reducing their in-person capacity. So facilities reported deferring lab testing and imaging specifically. American region countries, we can see here, reported lab testing and imaging deferral rates that were higher than the global average, while African region respondents reported lower deferral rates, and European countries kind of coming in the middle there. For care that could not be deferred, patients were shifted to telemedicine alternatives, and some facilities also reported increasing prescription pill counts to reduce the need for in-person visits. So we asked our respondents to report telemedicine both during the month of highest COVID impact and during the month of survey completion. During the month of highest impact, we see European and American countries shifted a large volume of their care to telemedicine. So the numbers here, this 40% and this 36%, are clinics that reported shifting at a minimum 75% of what would have been in-clinic care to telemedicine. This telemedicine was a combination of both audio and audiovisual services provided both on phones and using computers. Notably, only the American region countries reported continuing this level of telemedicine in the survey completion month, so in the current month. So after we see the peak of COVID cases in that March and April, we see a pretty rapid decline in the use of telemedicine everywhere, and then it's only retained at that high level in American region. While respondents in the African region didn't report high telemedicine use, 95% of African respondents had an increased pill count for patients, so shifting from a 1-month prescription to a 2 or 3 month prescription. We think this might have been an easier transition for facilities in the African region if they had already established 3-month prescription systems and protocols for patients living with HIV on antiretroviral therapy. Most facilities, regardless of region, did use individual outreach communication techniques as opposed to using kind of more widespread facility announcements or radio or print media. So reaching out one-on-one to those patients. While the pandemic has created some clear barriers to hepatitis elimination, we were interested in how new investments in health system infrastructure as a result of COVID could be potentially leveraged to support hepatitis elimination goals for the long term. 91 of our respondents identified at least one COVID-related change with the potential to benefit long-term hepatitis care. Overall, investments in training and improved lab testing platforms, which are seen here, were the key opportunities that were identified as opportunities to leverage pandemic-era investments to make progress towards hepatitis elimination. So this one's a doozy, so I'll walk you through it. While we know COVID decreased global capacity for hepatitis prevention, testing, and treatment, we have recorded a variety of mitigation strategies that facilities implemented. And to help evaluate improvement or recovery for our clinics, we wanted to ask participants about their overall clinic volume during the month of highest COVID impact, and then again during the month when they completed the survey. Again, we're using pre-COVID months as a baseline for both comparisons. What we have presented here is the reduction in patient volume during the highest impact month, which is in blue. So those dots kind of hover near the top of the graph. And then the current month represented in red dots. And so that's hopefully lower on the graph. The green lines here indicate the change between the 2 months and the recovery in clinic volumes seen comparing March and April volume levels to September and October. So we have facilities that reported deferring 100% of their clinic visits, 75% of their clinic visits, and then that dropping to no longer having to defer or skip out on patient care, or having only 1 to 25% of their patient care deferred, which is excellent. Facilities in the American region did report larger improvements than other regions, but it's important to note they also had some of the highest initial deferral rates. Conversely, African region facilities reported smaller improvements, but they did have lower rates of deferrals during their month of highest impact. And we do know, based on surveillance, that the African region countries experienced their initial COVID outbreaks a little later than the European and American regions, which may in part account for the delay in the clinic volume changes that we were able to document for other regions. And then this graph, of course, does not account for how countries responded to subsequent waves of infection. So we just have that measurement from the March or April month and then the September, October month, not looking at when we were seeing second waves or resurgences. Overall, as we look forward, we hope that the hepatitis community will continue to adapt and disseminate lessons learned for the safe continuation of service delivery despite the pandemic, while hopefully capitalizing on the opportunities we've seen already for innovation and collaboration as it relates to continued efforts in hepatitis elimination. To that end, I am very excited that we have several of our respondents here today to share their experiences and insights as they relate to hepatitis testing, care, and treatment during the COVID response. I will, with that, turn it over to our wonderful director, Dr. John Ward.
Thank you very much, Jessica. For those in the audience, if you have a question about the survey or as we move through our conversation, just put them in the chat box. But let's turn to, thank you again, Jessica, that was very well done. And thank you again for the survey analysis. Curious for those on our panel today, what were your thoughts about the survey and what you're thinking about that? I was going to start with Wendy, since Wendy really helped us make connections in Africa to get many of the respondents' comments in the survey. You know, Jessica was mentioning regional differences, and Wendy, I was just curious, what was your take on, you know, from your feedback through the ECHO network, what has been the impact of the COVID-19 response in the African countries you've been working in and with?
So I think particularly in the sort of southern, so if we look at South Africa, Zimbabwe, Zambia, Botswana, we seem to be hit far greater by the COVID pandemic, and then East Africa occurring later. And I think what was really quite useful was the use of our echo clinics, and we expanded it. So we've been running these viral hepatitis echo clinics for about 3 years, but we rapidly expanded that to deal with COVID. And we were running weekly COVID-19 clinics addressing how COVID was affecting both management of patients, generally impact on various different disciplines. And I think the use of that platform to expand knowledge was very helpful. It actually set up increasing networks across sub-Saharan Africa, which I think we can definitely use going into the future. I think, as you know, there's been quite a lot of denial regarding COVID across sub-Saharan Africa. And I think these sort of networks which have access to everybody has access to really helps to disseminate factual knowledge across the region. So I think particularly that the southern area of sub-Saharan Africa has been particularly badly affected by COVID and impact on viral hepatitis services. If we look at our own in South Africa, I mean, despite hepatitis B still being endemic here, rising hepatitis C infections amongst injecting drug users, in fact, the general knowledge around viral hepatitis amongst both the medical fraternity and the general public is really very, very poor. And after many years, we actually eventually got national guidelines published, but that really happened at the end of December 2019, beginning of 2020. And the plan was really to roll that out with the teaching around the rollout of dolutegravir, combining HIV and viral hepatitis. So we were very excited about that. But that really was actually put on hold with the pandemic starting. And so that really was very, very disappointing, because that would have been one way of actually starting to improve access to screening for viral hepatitis and incorporating it within HIV. And unfortunately, the resources were directed to managing COVID-19 and now the vaccine. So that's been a bit of a stumbling block in terms of, we were hoping 2020 was going to be the big breakthrough for viral hepatitis.
Maybe it still can be, but just a little bit 1 year later or so. You can take that. Julie, about Dr. Marinho, how did the survey results that Jessica went over, how did that reflect the impact of your work in Portugal?
I think, in my point of view, the differences are huge because of the different countries, different regions. Even in Portugal, there is a difference between the north, south, and the west and the east. So and also it depends on the hospital, on the characteristics of the team that is going to treat these patients. I think it depends also on the leaders we are in the field. So my point of view is different realities. The impact in Portugal has been huge. We are right now in the peak of the pandemic. The mortality has more than doubled the normal mortality. People are afraid of going to hospitals. People are afraid to go to outpatient consultations. We created special management for the outpatient consultations using telephone, but these patients don't have phone numbers. They change frequently phone numbers, so the impact has been huge in our country. We reduced the number of treatments in the last year about a half, 50% of the normal treatments in 2018.
Thank you. I have some other questions come to mind, but I think we'll go around and hear from Dr. Singh. What, again, how did there was sort of the summary of the results that Jessica presented, how that line up to your own personal experiences, or there's some different aspects you'd like to bring up?
Sure. So for, in the States, a lot of our referrals for treatment of viral hepatitis come from primary care providers. And especially during the hardest hit months in this part of the US, which was March and April predominantly, people just stopped seeing their primary care doctors and seeking any kind of care, really. And even urgent care was delayed. And so we saw a pretty sharp drop off in referrals, especially in regards to viral hepatitis and in general hepatology. In March and April, we were actually just kind of catching up from our 4 to 6 week backlog of patients that we, the referrals that already come in. So it was actually very surprising, because we knew that, what was coming in was not what was the need in the community and at large in our state. And so that was difficult to see. Thankfully, through the use of mail order pharmacies, a lot of our patients that were, actually in the middle of hepatitis C treatment or on chronic antiviral therapy for hepatitis B were able to continue. We were able to, extend refills, and mail order pharmacies were still up and running and actually more robust during that time, thankfully. So there wasn't an interruption, at least, and most of our patients' care, which was a very positive thing. And we had a skeleton platform for telemedicine set up, mainly used for those patients that lived 4 to 8 hours from our facility in rural sites. And so we were able to pretty quickly adapt that skeleton structure to our local patients as well as our extended network. And so that, I think, was a really, really key thing for us to be able to still have our patients plugged into care. That was really significant, especially our post-transplant population, where we had 2 full clinics a week that went from 2 full clinics to no clinics for a period of time when we were, from a state perspective, we were restricted from seeing patients in person. And so we had to adapt technology to be able to actually support our patients.
Thank you. Thank you very much for those opening remarks. So Bernadette, now I really wanted to end with you because you're out in the community. You're in a much different, care environment than more clinic-based clinicians that we have on the panel today. So I was very interested in how, again, these results line up to your own experiences, or what are the other experiences that come to mind for you that would be important for us to appreciate.
For sure, thanks. So I think the interesting thing is everything that everybody's said we've experienced, right? So at the very beginning, Toronto was in a lockdown, and so we were concerned about people's ability to actually go to pharmacies and pick up medication or make it to visits, because it wasn't clear at the beginning what level of policing of the lockdown would end up happening. So for a month, we just suspended treatment starts altogether. So we continued to support people who are already in treatment, but decided to give it a couple of weeks to figure out what was actually going to be happening. And then because a lot of the hospital systems ended up going to essential visits only, we actually saw the number of referrals we got skyrocket in the following months. So because there was less access through hospital-based clinics and our community clinic was still running, we were 2 or 3 times higher than what we typically were on a year-to-year average. So we were able to pick that up, and some of the things that we ended up doing. So likewise, people oftentimes don't have the same phone number or any phone number at all. So we did a device drive, and we were able to provide people with cell phones or tablets along with 3 months of free data so that they could connect with their clinic and have on-treatment conversations with their clinical providers. So that was really helpful in getting people engaged and keeping them on track with treatment. Another thing that ended up happening, and part of this was because of our experience with long-term care and the COVID outbreaks there, that congregate living situations ended up becoming a bit more of a focus. So we took a look at a lot of shelters, and because high density shelters, we were concerned about the impact of COVID there. Within Toronto, there was a kind of like a decanting of people from the shelters into hotel sites. And so people were in single unit hotels. And we were able to work with the staff and the clinical staff that were sometimes present at these hotels to engage people and start people on treatment that we otherwise wouldn't have, because of this kind of like temporary suspension of physical movement of individuals who are oftentimes, moving from place to place a bit more. But correlated to that, which unfortunately, when you have 2 pandemics that are dropped on top of each other, the opiate epidemic and pandemic within Canada has ramped up as well. So we saw a lot more overdose deaths and a lot more overdose deaths within hotel systems than what we did before. So we were up about 38% in overdose mortality during that time. So we started looking at other programs, and one of the programs that we started up during this time was a safer opiate supply program. So it was prescribing prescription grade opiates to replace street-based opiates for individuals who have high dependence and high risk of overdose. And so if you're having a daily dispense of opiates, it's really easy to start hepatitis C treatment with those individuals as well. So we really looked at partnering in places that we could and keeping referral pathways open as much as we could for the people that we're working with.
No, that's really an amazing persistence and focus on maintaining your focus on hepatitis while still recognizing the demands of COVID-19 and how you have to be flexible and try to recognize how both need to be tended to. I think next month we'll be publishing in this series a report from England that similar to your description of the homeless sheltering in Toronto, where there was increased sheltering made available for people who were homeless in England outside of London. And so they took that as an opportunity to develop a testing and treatment program. They found about a 17% prevalence, and then they began to treat people there. And it sounds like you sort of took this opportunity as well. Did I understand you correctly?
Yep, that's exactly what we did. So so we started, it likewise with the ECHO network, we started with just reaching out to providers who were in these places and doing kind of like co-treatment alongside people until they ended up getting a little bit more comfortable with initiating and supporting people on treatment. So the beauty about hepatitis C is we just really need to get out of our own ways. The treatment isn't difficult, it's about really increasing access to it. So so we onboarded people to help us in this whole thing.
Yeah, and then quickly, what to that point, I think testing is so important because the treatment is fairly simple now. So, what was your testing strategy in these homeless situations?
Yeah, so as a nurse, I'm typically the one who does labs on everybody that I meet. So part of it is just trying to make sure that there are as few individual appointments as possible for people. So unfortunately, people still sometimes see a viral load as being a complex test to do, and specialty labs are required for that. So it was really about kind of walking people through that a few times until they were comfortable doing it, and then doing testing on site as much as possible.
That's great. Dr. Singh, I know you're very a large part of your work is around transplants. And I didn't know how transplant volumes changed over the COVID course, either because donors weren't as available or maybe they were, or because of just, again, because of the restrictions in the clinical environment. So any comments about that, please?
Sure. So actually, similar to what Bernadette was seeing, we were seeing a lot more overdose deaths in and around Michigan. So we did have more donor availability in that way, sadly. But for about a month at the peak of the pandemic in this area, we actually had to shut down all transplants at Henry Ford because we did not have any beds. And this is a almost 1,000 bed hospital. But we ran out of space, and ICU beds especially were at a premium. And so we could not safely proceed with transplanting. So our waitlist mortality definitely went up. And we actually, if we did end up having acute liver failure patients that came in to our system, we wanted to transplant them, but we didn't have the capability. And so we actually would have to transfer them to local hospitals, within a tri-state catchment area to try to get them a transplant, especially when we had status 1A patients come in. And so it was a very tricky, stressful time in terms of transplant and not being able to offer that life-saving measure to so many of the patients that have been with us and on the list with us for so long. So, it's something I hope we never see again. But it was if you don't have the space and you don't have the staff, it's really difficult to do this.
So the routine is fairly much pre-COVID now, as far as transplants are concerned?
So now our transplant volumes are back up. We are fully operational. We had a second kind of wave a few months ago here at the end of November, beginning of December, where we were running out of hospital capacity again, but it's gotten better, thankfully, and so we are back up to pace now. Now a lot of the issues that we're running into, but we've learned from our colleagues around the world, a lot of our pre-liver transplant patients, the decompensated cirrhotics, are persistently testing positive if they've had COVID. So we're seeing PCR tests that have remained positive in this population and a lot of our patients on the list. But we've learned that critical threshold values are important in kind of discerning true infection from just kind of lingering PCR positivity. And so initially we had several patients on hold for several months actually, but we've learned, and so we no longer are doing that, and they're able to accept offers, and so we're back pretty much to functioning.
That's good. That's good. That's good. So Wendy, if I recall your survey correctly, it seems like you had a particularly large drop in testing in South Africa, and then subsequent referrals of patients for treatment from those test sites. Is that correct? And what were your testing sites, and how has that changed over time? What's the situation now?
So absolutely. So South Africa doesn't have any dedicated viral hepatitis screening program, campaigns like Know Your Status as they are for HIV. So we're really dependent, unless somebody presents clinically with liver disease, on referrals from blood transfusion services, the Defence Force who screen, or people traveling overseas for work permits who need screening. And so, in fact, normally we will get about 10 referrals a week with hepatitis B, maybe 5 referrals a week with hepatitis, 3 to 5 hepatitis C. In fact, that actually stopped completely. With the level 5 lockdown, in fact, the problem was that you actually were not allowed to leave your house, except for essential services. There was very limited transport, except for a couple of hours in the morning and the evening. So, in fact, the usual drive that the blood transfusion services would do in factories, schools, universities actually just stopped completely. So we had really no referrals until about beginning of November. Then they started coming through again, 2 or 3 a month, nothing like we used to. And then unfortunately we hit the second wave in December, and we're just coming out of that. So they've dried up completely again. So that really had a significant impact. The hepatitis C referrals have usually been from our NGOs, which look after, provide the sort of harm reduction services for our injecting drug user clients. And in fact, that dried up completely. That was one of the big problems, in that many of them were obviously homeless, and during this lockdown, they were really placed into shelters with very limited access initially to the harm reduction services. But in fact, that had quite a positive spin-off, because in fact, NGOs then started visiting them, started having better sort of collaboration networks with the local authorities, with municipalities. So I think that long-term will have a positive spin-off in really demonstrating the need for appropriate harm reduction services. So although they were affected quite significantly, I think going forward, those networks have now been developed. But yeah, it's been a major problem. So we're just coming out of the second wave, which has been very, very difficult. In fact, the numbers were much higher mortalities, higher ICU requirements. And I think it's going to take time. We're still in a level 3 lockdown, so you can't go, people are working from home, you can't do these mass drives. So I think this is going to have a significant impact long-term in getting people back into referral bases. Yeah.
Thank you.
We were lucky that we could continue our clinics, but the referral basis was really severely impacted.
Yeah, it sounds that way, yes. We'll see how that evolves over time. It was good to hear that maybe harm reduction has some new appreciation that maybe open some opportunities in the future. We are getting a couple of questions about your experiences through your ECHO network, questions about whether was hepatitis care particularly compromised for rural populations, or you were mentioning Southern Africa versus Eastern Africa, but even, were there differences between urban and rural populations as best you could learn from the network?
Yes, I mean, absolutely. If we just look at South Africa, we've got a few dedicated centers of excellence, which, very good access to medical care, but a large proportion of our country is actually rural. We have provinces that are actually very poor, very, in terms of medical resources, very underserved. And unfortunately, in those areas, particularly the Eastern Province, Eastern Cape, that is where COVID really hit very badly with very high mortality rates. And in fact, so our spokes go out into these rural areas, but the problem is the doctors were so overwhelmed with managing COVID that they were actually unable to really partake regularly in the viral hepatitis echo programs. They kind of shifted their attendance to the COVID-19 echoes. But I think with that, you've increased the exposure to how echo works, and hopefully now this year we can expand the viral hepatitis. I think it's really just knowing how it actually works and how convenient it is. But the impact in the rural areas in terms of delivery beyond COVID was severely impacted in South Africa.
A follow-up question was around vaccination. Are you aware of any, I don't know how much work you do in vaccinations, Wendy, but I know birth dose is not well delivered in all of Africa in any event. It's only about 10% coverage, but even for infant immunization, which tends to be, quite higher, any feedback about vaccine delivery now?
Yeah, absolutely. So the birth dose vaccine implementation in South Africa was supposed to start last year. That's really been put on hold. But the real concerning, I mean, that's obviously concerning, but the real concerning is if we look at our EPI program, where we get the hepatitis B vaccine at 6, 10, and 14 weeks and a boost at 18 months, really both with the strict level lockdown and no access to actually transport, in fact, the vaccination rate dropped significantly. And then as things actually started relaxing, mothers were actually scared to take their children to day hospitals, to primary healthcare clinics. So I think that's again, and really to be able to track that, who hasn't been vaccinated and have that catch up is going to be very, very difficult. We know even in the Western Cape where I am, if we look at, we're still looking at about a 7% surface antigen seroprevalence, and amongst that, pregnant women, still 20% of those being E antigen positive. So the risk of mother-to-child transmission, early childhood transmission, is still very high. So I think this is going to have an impact down the line for decades to come, actually.
Absolutely. I mean, quickly, in the United States, infant immunization went down for hepatitis B, but birth dose did not, because women continued to deliver in the hospital where the birth dose could be delivered. So that was the situation here in the U.S. Dr. Singh, you have a question for Dr. Spearman. You want to go ahead and ask yourself, please?
Yeah, I was just wondering how there's been so much buzz and concern in the United States about the different variants coming out of the UK and also South Africa and Brazil. How has the South African COVID-19 variant affected your, clinical capabilities?
So yes, I mean, it's been quite significant. So that second wave started, or peaked in the last week of December, first week of January. And really the numbers were double that in the first wave, much more rapid rise and fall, and a very different sort of profile of individuals. So the younger, particularly, we had a number of super spreading events amongst people finishing matric, end of year parties, and that really just set that second wave off. So definitely much more infectious. It's very difficult to say, and certainly we've had a lot more admissions to on high flow nasal oxygen into the ICU. It's difficult to know at this point, is it just because the numbers are so high that we're seeing increased mortality? But those of us who are looking after patients really do feel that that the mortality is significant. We've seen young individuals, pregnant women. Yeah, it's been really quite difficult, particularly for our younger doctors to cope with the young deaths I mean, all deaths are difficult, but if you're older with a lot of comorbidities, but when it's a 30-year-old, 25-year-old, 40-year-old, it's very difficult. So definitely the rate of infectivity much, much higher. And that's the problem with the AstraZeneca that we were hoping that we're going to, it hasn't been shown probably to be effective in this new variant.
Yeah, very disturbing. We're following it here in the US closely. I don't know if you like it to be called the South African variant, but that's the way it goes. Anyway, Huey, Dr. Marinho, I was curious, what % of your time now is COVID-related work? I mean, consultations on COVID patients who have liver disease, and what % of your clinic time is now devoted to COVID-19 patients?
In our clinic?
Yes.
In our hospital?
Your hospital, well, for you yourself as a physician.
For us, we don't deal with COVID patients. Our department is free from COVID patients. We have special wards. Almost 1/3 of our beds are now devoted to COVID patients. 90% of the intensive care unit COVID patients, but we have some gastroenterologists, some hepatologists working in these units, but are separated from the normal wards, so-called. So we don't deal with patients. We have some patients in our wards without expecting. A lot of nurses and some doctors affected. The liver transplant programs in Portugal, which are one of the best in Europe, the second in Europe in terms of population, has almost locked down with patients infected. The team, the professional team, doctors and nurses infected also, so almost stopped. Only for urgent
one population.
cases.
One population I'm particularly concerned
Only
about.
for urgent cases.
Sorry. Go ahead, please.
Only for liver transplant, only the urgent cases were done. So the number of donors has decreased a lot, so almost stopped.
One patient population I'm particularly concerned about are patients with cirrhosis at risk for liver cancer, and the monitoring, the surveillance for development of HCC and the early detection of that really improves the survival. And I'm concerned that that's hard to achieve, that frequency in routine times. I'm particularly concerned in COVID times. And so I wanted to start with you, Huey, just to see how are you continuing to provide care for patients with cirrhosis at risk for liver cancer and the screening that they need for early detection of cancer?
So we have maintained the outpatient consultations, 50% with phone. We don't have telemedicine, visualizing the doctor and the patient, but is very difficult right now to do the ultrasound. The ultrasounds are late. Almost 1/3 of the ultrasound we sent outside hospital. The hospital is full of COVID, is invaded by the COVID, so it's very, very difficult to do the normal examinations, the ultrasound. So we have seen some patients with increased alpha fetoprotein, with some nodules. Yes, we are expecting to have more deaths by liver cancer.
Yeah.
The patients with decompensated cirrhosis, we think some of them are dying in outside hospital at home, because the numbers of the patients in the emergency rooms is decreasing a lot, because the population is afraid of going to hospital. Every time in the news they are talking about the chaos in hospitals, lot of ambulances, 50 ambulances outside the hospital. So people are afraid and they don't go to hospital. we are seeing less and less decompensated patients with cirrhosis, with ascites. Perhaps they are dying outside, even without reaching the liver transplantation center.
And
So
where
the
that,
impact is double, I think.
and Wendy, how about you? What's your take on the surveillance for HCC and how well that's going in COVID Europe?
Yeah, so I mean, we decreased our numbers by about 40%, but we kept those patients with advanced fibrosis, cirrhosis coming to the clinics, and we had a system where our clerical assistant, who's been with us for 10 years, actually knows the patients and reminded them that they should come. And we were very fortunate that our radiology department continued to provide us with regular ultrasound surveillance. So I think the ones that remained in care were able to get their routine surveillance. That wasn't a problem. The problem is, as colleagues have mentioned, that in fact, patients with decompensation were not being referred either because doctors thought that it was too unsafe to send them, or they were concerned about coming in. So I think we are going to be, because of the lack of referrals, even though our policy was that anybody who was decompensated, who had newly diagnosed liver disease, would get access as a new patient, there was still this great reluctance to refer from outside. So I think we're going to see that the impact of that down the line. I think we have been fortunate that our hospital did allow us to continue to do surveillance and to keep these patients in care at a time where most of the general wards were basically overtaken by COVID, and we were fortunate to be allowed to keep our dedicated liver beds as well. So I think we were relatively fortunate in how we were able to provide care for our patients. But in terms of our liver transplant program, we didn't transplant anybody during 2020. And obviously there was significant mortality on the waiting list, and that included our pediatrics as well. So, and that was just really no access in ICU beds, as been mentioned. And in fact, just donors weren't referred.
Yeah, the secondary impact of COVID-19 on excess deaths from other causes is something that I'm sure will get quantified at some point. Just models is what we have now, but it will be interesting to see the data. And just so I understand the impact of that, what's your normal number of transplants per year at your institution, since you went to 0 in 2020?
So, I mean, we have a very small program. We only do about 60 a year, we don't have a living related program at our center. They have that up in Johannesburg. But yeah, it's still significant to not be able to transplant anybody.
Yeah, absolutely. And Dr. Singh, what about you at Henry Ford about HCC surveillance? Then you can ask your question.
Sure. So for our HCC surveillance during the peak of the pandemic, we actually abode by the AASLD kind of recommendation, which was you could defer routine surveillance for 2 months. And so we did. Built into our order set, through our electronic medical record system was actually radiology placed a stop. We had to tell them if it was COVID sensitive imaging or not. And so we weren't allowed to just order anything during that time. But after the fact, now we are actually meeting as a group within the departments to try to figure out if there's a better way to capture, because even without COVID, it was hard to get patients to do our routine, every 6 months, whether it was even just an ultrasound, if not a more advanced cross-sectional study. And so we're actually looking at ways to try to improve compliance, whether it's through remote monitoring or calling, coming up with a system where we're not losing those patients, especially those. I think the hardest population for us to continue screening is those with advanced fibrosis that we have cured of viral hepatitis C, and trying to keep those patients engaged. And so because that was one of the unfortunate things that we did see for those very few that were coming into care urgently, we would see this massive metastatic multifocal large lesions in that population coming in, and it was dramatic, but it had been months and months of not seeking care. despite us trying to reach out. So now we are back to normal with HCC surveillance, but we are now kind of retrospectively looking at ways to improve our surveillance in general.
That's great. That's great. Let me go ahead and ask Bernadette. I know you mentioned for your patient population, are you getting a lot more referrals because of the closure in your hospitals in Toronto? So I don't know if do you have any perspectives on, when you did have patients that looked like they had severe liver disease, did you have problems getting referrals for those clients you were looking at in your settings?
Yeah. So interestingly, the majority of people who have decompensated cirrhosis, we end up referring them to some of the specialty liver clinics, so hospital-based liver clinics. And the hepatologists within those clinics would actually refer them back to us and say, you've got a better relationship with them. They're more likely to follow up with you. We can continue to, send your blood work results to us and we'll give you recommendations. And so we would, so we do a lot of co-management of care for people with decompensated cirrhosis within the communities. And the beauty of it is they're already rostered with the hospital and the hepatologist. So if they needed to go in for an emergency scope, or if they need to get tapped or whatever else, it's a very easy intake process for that. So we do a lot of co-case management in that way for our people who are more complex decompensated cirrhotics. And if we're talking about the imaging, like definitely there's been a decrease in imaging and imaging within hospitals. Part of what ended up happening then is community-based like labs and ultrasound facilities would still be open and take people, but we wouldn't necessarily have that baseline imaging to look at. And so the quality of the reports were not necessarily what we needed for kind of an in-depth HCC screening. So that definitely did end up making a difference for some of the people who even who did end up going for the ultrasounds. We didn't always get the reports that we needed to make a decision on. Yeah.
Question was about nosocomial COVID-19. Have there been any issues in the institution? So for the panelists on the call, either actual known instances of transmission to healthcare workers who unfortunately had bad outcomes of COVID-19, or any problems getting personal protective equipment, which has been an issue in some hospitals in the U.S. But I'll start with Dr. Singh, who asked the question.
Yeah, we're, I think similar to Dr. Marinho's, the question you had posed to him, we typically, as a consultation service, both in the hospital as well as in clinic, are not, exclusively seeing COVID positive patients virtually. And in the hospital, we typically will also offer virtual service to them. But one of the things that I've started noticing rounding inpatient over the last 3 months is that patients I initially see who all have to be screened, in the ER or before transfer from outside hospital that were initially negative turned positive within a matter of a few days. And so, and we've even had post-liver transplant patients immediately after transplant, who obviously we screened ad nauseum prior to transplanting, become positive within a span of a few days. And so we have to assume that this is nosocomial transmission. We've had some terrible outcomes, unfortunately, in that fresh post-transplant period. But I'm just wondering how others are, seeing this and dealing with it. We're grateful in Detroit to have the vaccine available, and most healthcare workers here who want the vaccine have been able to get it at this point. But I know there's still some question of whether the vaccine prevents transmissibility, but we are still in full PPE when we see patients, even on the wards, even when we know they're negative. But I'm just wondering, curious as to others' experiences. We are seeing a large uptick, much more than we did at the peak of the pandemic.
Interesting. Any thoughts on that from others as far as the risk of transmission within your institution?
Okay.
Go ahead.
Go ahead.
Go ahead, Huey.
Wendy. Ladies first.
Okay, ladies first.
All right. So, I mean, during the first wave, we certainly saw probably more nosocomial. Also, not quite sure whether it was just the delay in actually getting access to screening. So there was, often there was, days delay in actually before the outcome came. So it's quite difficult to know, was it nosocomial or did they already have it? In the beginning, we had really quite separate teams looking after COVID, looking at general medicine, looking after subspecialties. But that really wasn't sustainable. So by the height of the first wave, all doctors were actually looking after general medicine, COVID, and if they were in a subspecialty, the subspecialty. So you were moving between these different components. And certainly we did see nosocomial, not as much as we expected, but usually after they'd been in the ward for about 5 days, usually complex patients with complex underlying conditions, and then outcomes were actually quite poor. I think what's interesting, we seem to have seen a lot more healthcare workers becoming infected in the second wave, and that might just relate to this increased transmittability, and it's particularly in the younger doctors, I think, that we're seeing it.
Thank you. Okay, Huey, Dr. Marinho?
For 9 months until January, it has been possible to have a 0 level of nosocomial infection. All patients admitted to our department had to be tested. All patients going to endoscopic unit all tested. But after that, at January, after Christmas time, the government opened the hospitals, promoting the visits at that time, also at the end of the year. So a huge epidemic at hospitals and all the healthcare facilities, like where the old people, but especially in our hospital, huge epidemic for healthcare professionals. For example, in my department, we are 150 health professionals, almost 25% of them infected. Before we have access to the vaccination. The vaccination did begin 1 month ago, 2 months ago, but it was like Singh was saying, patients admitted to our hospital, our ward, with a negative test, but that after 3 days, 4 days, 5 or 6 infected with COVID. So we think it has been after the visits that were open to all hospital, all patients.
Right. That's interesting. Thank you for raising that question. It does bring to mind the quality of the test and sensitivity of the test and how some negatives can be false negatives when they on arrival as well. So I think that must be part of the equation, I would think, for some of these patients. And then Bernadette, you were mentioning how you're in these congregated settings where transmission is at high risk. And so, how did you and your other community health workers maintain good infection control and protect yourself? And did you or did any of your colleagues become infected while providing care in these settings?
So we've been incredibly lucky so far, and we have a really great relationship with the infectious disease team at one of the local hospitals. That relationship started about 14 years ago when we started doing Hep C treatment in the community. So very early on, we adopted universal masking for all staff as well as clients coming into the center. Syndromic screening happens on a regular basis. No communal places for lunch or break rooms, that kind of thing. So that was all done very early on. And within the congregate settings, we do targeted testing. So what we oftentimes find is staff individuals test positive first, and then we go into the congregate settings and do mass testing of individuals every 3 days, and take people out into isolation centers for the infectious period. And we're able to kind of, the lovely thing about COVID is by the time you're symptomatic, you've already spread it to anybody who's a contact, right?
Yes,
Yeah.
right.
Yeah.
Never heard it termed a lovely moment, but that's
yeah.
Go
So
ahead.
mass testing is basically and isolating people within the shelters situations, but it does really seem to be much more, because community spread is so high right now. It does seem to be that it's workers who are bringing it initially into shelters and then passing it on to people within congregate situations. So really working at, trying to make sure that break time, having a meal together, having a smoke with your coworkers, really working on that side of things.
Great, thank you. Well, I could keep going. It's a great conversation. I enjoyed talking to all of you. I think we're out of time though, so we'll have to wrap it up. I'm going to thank all of you for coming on and sharing your experiences. Thank you for your work to maintain hepatitis care as well as providing care for patients with COVID-19. Thank you, Jessica, for your analysis in your article. Look forward to working with you all in the future. And thanks again. Take care. Bye-bye.
Thanks.
Bye.
Bye.